Welcome to the Deep Dive, the show where we cut through the noise and get straight to the essential insights you need to be truly well informed. Maybe you or someone you care about has recently been diagnosed with diabetes, or maybe you're just really curious about how these, well, pretty crucial medications actually work. It can feel like wading through a whole new language, right? Don't worry, that's what we're here for. Today, we're taking a deep dive into the fascinating world of diabetes medications. Our mission is basically to unpack the complexity, explore the different types of drugs, understand how they work, and, what makes each one unique, all drawn from a stack of detailed medical sources.
Exactly. And we should probably start by briefly setting the stage. When we talk about diabetes, we're generally looking at two main types. There's type 1, which is an autoimmune condition where the body essentially stops producing insulin. And then type 2, which is the most common type, where the body either doesn't use insulin effectively or maybe doesn't produce enough of it. The central challenge for both, though, is chronic high blood sugar, which, if it's left unchecked, can unfortunately lead to serious complications. We're talking kidneys, nerves, heart.
Right, serious stuff.
Yeah, and that's why medication is often a really crucial part of managing the condition.
Okay, let's unpack this then. We've got quite a lot of ground to cover, it seems. But we're going to try and make it clear, interesting, and hopefully easy to grasp. Promise.
That's the plan. Our mission today is really to equip you with a solid understanding, not just what these medications are, but why they matter, and how they fit into the bigger picture of diabetes care. It's about making sense of the science so you can feel more informed.
Okay, so before we get into the specifics of, individual drugs, maybe let's look at the main strategies. The battle plans these medications use to fight high blood sugar. Thinking about it like that in terms of core strategies sounds really helpful.
It is, yeah. There are basically 5 main approaches these drugs take, different angles to tackle high blood sugar. First, we have insulin sensitization. This is all about making your body's cells more responsive to the insulin that's already there.
Okay, like making them better listeners.
Exactly, like tuning up an old radio so it hears the signal clearly again. That's what these drugs help your cells do with insulin. Second, there's stimulation of beta cells. This directly encourages the pancreas, the organ that makes insulin, to produce more of it.
Got it.
Third, we can slow glucose absorption right from the food in your gut. There are drugs that target either carbs or starches specifically.
Preventing that big sugar spike after eating.
Precisely. Then there's alpha amylase inhibition, which is a bit more specific, slowing down starch digestion. And finally, a newer approach, SGLT2 inhibition. This one basically tells your kidneys to just get rid of more glucose through your urine.
Interesting, a totally different route.
It is, and understanding these basic mechanisms is really key. It helps you see why different drugs might be chosen and how they fit together in a treatment plan.
Okay, that framework makes sense. Now here's where it gets really interesting, I think, the direct approach. In insulin itself, this hormone is just absolutely critical, especially for people with type 1 diabetes who don't make it at all.
Right, absolutely critical. And it's also very widely used in type 2 diabetes, especially when other treatments aren't quite cutting it.
But there seem to be so many different types of insulin. How does anyone, a doctor or a patient, actually navigate that complexity? How do you find the right mix?
That's a fantastic question because it's definitely not one size fits all.
Yeah.
You could think of insulin like different tools for different jobs or maybe different gears on a bike. You have your sprint gears, the rapid-acting insulins, things like Lispro, Aspart, Glucine.
Okay.
They kick in really quickly, maybe 15 minutes, perfect for managing those mealtime sugar spikes.
Yeah.
They peak in about an hour. It's like an immediate power boost.
Got it. Mealtime coverage.
Yeah. Then there are the cruising gears, the short-acting like regular insulin. Takes
Yeah.
a bit longer, peaks around 2 to 4 hours. And the intermediate-acting types, like NPH, these peak maybe 4 to 10 hours out, giving a more sustained effect. They're kind of your steady workhorses.
Right, covering the gaps between meals a bit more.
Exactly. And finally, the endurance gears. These are the long-acting insulins, like Glargine or Detamir. They offer steady background control, often for a full 24 hours, usually without a big peak. Keeps things stable between meals and overnight.
Okay, like a baseline.
Precisely. And now we even have ultra-long-acting insulin, like insulin Diglubac. That can last up to 42 hours. Quite remarkable.
Wow, 42 hours. That's impressive. Now, beyond just injections, what about insulin pumps? I hear more about those now. They deliver insulin continuously.
Yes, pumps are another important method. They typically deliver rapid or short-acting insulin continuously, kind of like that baseline we mentioned,
Hmm.
and then the user can give themselves extra doses or boluses for meals or if their blood sugar is high. Newer systems are even more advanced. Sensor-augmented pumps use a glucose monitor feed, and hybrid closed-loop systems can even automatically adjust the insulin delivery based on those readings.
So what are the real practical benefits and I guess the challenges for someone using a pump?
Well, the big benefits are flexibility, more freedom with meal timing, and they often lead to significantly reduced glucose variability, smoother control.
Less up and down.
Exactly. It mimics the body's natural insulin release more closely. But you're right, there are downsides. They can be expensive. There's always the potential for mechanical failure, a blockage or something. And they absolutely still require frequent self-monitoring. You need to make sure it's all working right.
Right. Technology isn't foolproof.
Definitely not. And what's really fascinating, maybe even a bit surprising, is when you look at the big picture, the research. A major systematic review found that despite all these different insulin types and delivery methods, no single form consistently comes out on top for key outcomes.
Really? Like A1C levels or avoiding complications?
Yeah, things like A1C, severe hypoglycemia, cardiovascular events, even quality of life or mortality. No clear winner across the board.
Huh. That's a profound insight. So it really implies the magic isn't in finding one perfect insulin, but in crafting that personalized regimen.
Exactly. It's about the meticulous art, you could say, of tailoring the approach.
So how does that work practically? How do doctors and patients actually create this finely tuned symphony of insulin that mimics their body's needs?
It's really a partnership. It involves very careful monitoring of blood sugar patterns, understanding the person's lifestyle eating habits, activity levels, and then adjusting insulin types and doses to match. You might use rapid acting for meals, long acting for that background control. It's about constantly refining that balance.
Takes effort then.
A lot of effort in communication. And it's worth mentioning, especially for pregnant individuals with diabetes, insulin is generally the preferred treatment if oral meds aren't suitable.
Okay. Now, insulin is clearly a lifesaver, especially for type 1. But it's not without potential issues, right? The most common one you hear about is hypoglycemia, low blood sugar. What does that actually feel like? How serious is it?
Yeah, hypoglycemia is definitely the most common complication and something people using insulin need to be really aware of. It can manifest in different ways. Mild or moderate symptoms might be things like headache, sweating, maybe feeling shaky, palpitations, confusion, irritability.
Okay, noticeable signs.
Usually. But in severe cases, it can lead to seizures or even loss of consciousness. So it's critical to recognize those early symptoms, especially because some people, particularly those with long-standing type 1, can develop what's called hypoglycemia unawareness.
Meaning they don't feel the warning signs.
Exactly. They don't get those crucial early warnings, which makes it much more dangerous. Treatment usually involves fast-acting sugar from mild cases juice, glucose tabs. For severe events, a glucagon injection is needed. It helps the liver release stored glucose quickly.
Okay. Are there other complications besides low blood sugar?
Yes, though less common. You can have hyperglycemia, high blood sugar. Sometimes this is due to the Somogy phenomena, basically a rebound high after a nighttime low. Or it could be the dawn phenomenon, which is a natural rise in blood sugar early in the morning because of hormones. We can also sometimes see hypokalemia, which is low potassium. Allergic reactions are rare with modern human insulin. And then there can be issues at the injection site, like lipohypertrophy, that's a lump of fatty tissue, or lipoatrophy, which is a loss of fat tissue. Again, less common now.
Right. Good to know the landscape. Okay, let's shift gears now and explore the vast world of oral medications. These seem to be the cornerstone for type 2 diabetes. You mentioned strategies earlier. Where do we start with the pills?
Let's start with the insulin sensitizers. These, as the name suggests, directly tackle that core issue in type 2 diabetes, insulin resistance, making the body more sensitive to insulin.
And the first one, probably the most famous in this group, is Metformin. It feels like it's almost always the starting point for type 2. What makes it such a workhorse?
Metformin is definitely a powerhouse, you're right. Its primary mechanism is pretty clever. It mainly works by telling your liver to produce less glucose, and it also helps your muscles and other tissues take up more glucose from your blood. So it hits it from two sides. It's incredibly significant. It's the most commonly used first-line agent for type 2, even approved for kids and teens. And here's a key thing. It's one of the only widely used oral drugs that doesn't cause weight gain.
Ah, that's huge.
It is. It might even promote some modest weight loss. Plus, it has a lower risk of hypoglycemia compared to some others, can improve cholesterol levels, and some studies even link it to lowered risk of all-cause mortality in people with diabetes, all while being very inexpensive.
Wow, that's a pretty compelling list of benefits. Are there any downsides? Any trade-offs or cautions people need to know about metformin?
Absolutely there are. The most common ones are gastrointestinal side effects.
Yeah.
Things like diarrhea, nausea, especially when you first start taking it.
Okay, temporary usually.
Often, yeah, they tend to subside. But there's also a rare but serious risk of lactic acidosis. It's a buildup of acid in the blood. That's why it's typically avoided in people with significant kidney or liver problems, severe heart failure, or issues with alcoholism.
Important contraindications then.
Very. And less commonly, it can lead to vitamin B12 deficiency over time, so that's something to monitor. Some people mention a metallic taste, too.
Okay. So metformin helps cells become more sensitive to insulin. Is there another way to do that? You mentioned another class of sensitizers, the thiazolidinediones, or TZDs, sometimes called glitazones.
That's right. TZDs, like pioglitazone, work differently. They target a specific protein inside your cells, called PPAR gamma. Think of it like a master switch. Activating this switch helps your body use glucose better and manage fats more effectively, ultimately making cells more responsive to insulin again.
Okay, different mechanisms, same goal of sensitization. How effective are they?
They can be quite effective at lowering A1C, often similar to metformin in that respect, and they also have a low risk of causing hypoglycemia, which is good. Dosing is usually convenient too, once a day.
Sounds positive. But I feel like I remember hearing some concerns about this class over the years, safety issues.
You're right to bring that up. It's really crucial. While glitazones offer benefits, there have been some significant concerns. They can increase the risk of heart failure. That's a major one. And they typically cause weight gain, often around 2 to 5 kilograms, or roughly 4 to 11 pounds.
Oh, wow, that's noticeable weight gain.
It can be, yeah. Along with edema or fluid retention and an increased risk of bone fractures, particularly in women. And pioglitazone specifically has been associated with a slightly increased risk of bladder cancer. Though, interestingly, one large study actually showed it could decrease certain cardiac events in patients with type 2 diabetes who'd already had a heart attack.
Huh, that seems contradictory.
It highlights the complexities, doesn't it? Drug effects can be multifaceted. And it underscores why careful patient selection and monitoring are so important with this class. Another drug in this class, troglitazone, was actually withdrawn due to liver damage years ago.
Right, so benefits, but definite risks to weigh carefully. Okay, moving on from sensitizers. What about drugs that directly boost insulin? Insulin secretagogues, you called them?
Yes, exactly. These essentially give the pancreas a nudge, telling it to release more insulin.
And the oldest group here are the sulfonylureas?
That's them. They were the first widely used oral anti-hyperglycemic meds. They literally trigger the beta cells in the pancreas to release more insulin. The modern second-generation ones are generally more common now, more effective, fewer side effects than the older ones.
Okay. But what are the downsides? If they make more insulin, does that mean more risk of lows?
Yes, that's the main issue. Their primary side effect is hypoglycemia. It's actually more common with this class than with many other oral treatments. They can also cause weight gain, again, often in that 2 to 5 kilogram range. And their effectiveness can sometimes wane over time.
And they only work if your pancreas can still make insulin, right? So not for type 1.
Correct. They stimulate your body's own insulin release, so they're only for type 2, and not suitable during pregnancy either. It's interesting. Clinical guidelines often rank them a bit lower than some other classes now because of the hypoglycemia and weight gain. But their low cost is a major factor. It keeps them a feasible and widely used option for many patients, especially when cost is a primary concern.
Makes sense. And then there's a similar but faster-acting group called the Meglitinides. How do they differ?
Right, Meglitinides, like repaglinide, they're often called short-acting secretagogues. They also stimulate insulin secretion, like sulfonylureas, but they work much faster and are designed specifically to boost the insulin response right around mealtime.
Ah, so you take them with meals.
Exactly. The key practical point is you take them with or just before meals. And importantly, if you skip a meal, you skip that dose of the medication.
Prevents lows if you don't eat, I guess.
Precisely. They can still cause weight gain and hypoglycemia, but the risk of lows is generally lower than with the longer-acting sulfonylureas because they wear off quicker. So, just to tie it back to the big picture again, you can see how drugs like metformin are addressing that root cause, insulin resistance. While these secretagogues, the sulfonylureas and meglitinides, are directly stimulating more insulin release, It's really about matching the therapy to the specific challenge the patient's body is facing.
That's a great summary. Okay, beyond making insulin work better or making more of it, what other clever ways are there to manage glucose with pills? You mentioned slowing absorption earlier.
Indeed. Let's talk about alpha-glucosidase inhibitors, like acarboses. Their mechanism is quite straightforward, actually. They work in the small intestine and basically slow down the digestion of starch.
So less sugar hitting the bloodstream all at once after a meal.
Exactly. It makes the glucose absorption more gradual, helping to manage those post-meal spikes.
Sounds useful. Are they common?
Well, not so much in the U.S. They offer a modest reduction in blood sugar and potentially a little bit of weight loss, but they're generally less effective than some other oral agents. And the main reason they're rarely used here is because of pretty significant gastrointestinal side effects.
Like what?
We're talking flatulence, bloating,
Hmm.
can be quite uncomfortable for people. They seem to be used more commonly over in Europe.
Ah, okay. Tolerability issue. Got it. What about the DPP-4 inhibitors, the gliptins? What's their unique angle?
Gliptins, like sitagliptin or saxagliptin, work in a really interesting way related to gut hormones. After you eat, your gut releases hormones called incretins, like GLP-1. These incretins naturally help your body release more insulin and reduce glucagon, another hormone that raises blood sugar.
Okay.
But your body also has an enzyme, DPP-4, that breaks down these helpful incretins pretty quickly. The gliptins work by inhibiting that enzyme.
So they stop the breakdown, letting the good hormones hang around longer.
Exactly. You get more mileage out of your own natural incretins. This leads to more insulin when needed, less glucagon. They're generally weight neutral, which is good and usually well tolerated. They offer a modest improvement in A1C, and the risk of hypoglycemia is low when used alone.
Sounds like a gentle approach. Any downsides? Cost.
Well, cost was a big factor. Until very recently, most DPP-4 inhibitors didn't have generics available, making them quite expensive. But sitagliptin, a really common one, did become available as a generic in July 2022. So that's definitely helping with accessibility.
Good news.
Yeah. In terms of side effects, there's maybe a slight increased risk noted for pancreatitis and sometimes infections or headaches, but generally they're well tolerated. If used with a sulfonylurea, they can increase the risk of hypoglycemia and weight gain, though.
Okay. Now let's talk about that other class you mentioned earlier with the unique kidney mechanism, the SGLT2 inhibitors, or gliflozins. These seem to be getting a lot of attention lately.
They really are, and for good reason. SGLT2 inhibitors like dapagliflozin, canagliflozin, empagliflozin, they represent a truly novel way to lower blood sugar. Think about your kidneys. Normally, they filter glucose out of your blood, but then they have these proteins, SGLT2 proteins, that act like pumps to reabsorb almost all that glucose back into your bloodstream.
So they recycle the sugar, basically.
Exactly. Very efficient recycling. What these drugs do is block those SGLT2 proteins. They jam the recycling machinery.
Ah, so the sugar doesn't get reabsorbed.
Precisely. Instead of going back into the blood, that excess glucose just gets flushed out of the body in the urine.
Wow, that's a very direct mechanism. What are the effects?
Well, it leads to lower blood sugar, obviously. It also typically causes some mild weight loss because you're losing calories in the form of glucose, and the risk of hypoglycemia is low.
And you mentioned other benefits earlier, beyond just sugar control.
Yes, this is where they become really exciting. Multiple large studies have shown that several drugs in this class have significant cardiovascular benefits. They reduce hospitalizations for heart failure, which is huge. And they also protect the kidneys, slowing the progression of diabetic kidney disease.
So they're doing more than just lowering A1C, they're protecting organs.
Exactly. That's why they've become a preferred choice, especially for patients with type 2 diabetes who also have heart failure or chronic kidney disease. It's a more holistic approach.
Plus they're pills, right?
Right.
So maybe preferred over injections for some people?
Definitely an advantage for patients who are averse to injections compared to something like the GLP-1 agonist we'll talk about next.
Okay, sounds almost too good to be true. What are the potential downsides or things people need to watch out for with this kidney mechanism?
Good question. The main concerns relate directly to that mechanism. Because you have more sugar in your urine, there's an increased risk of urinary tract infections, UTIs, and also genital yeast infections.
Makes sense. More food for the bugs, so to speak.
Sort of, yeah. There's also a rare but serious risk of diabetic ketoacidosis, or DKA. That's a dangerous buildup of acids called ketones in the blood. What's tricky with SGLT2 inhibitors is that this DKA can sometimes happen even when blood sugar levels aren't super high. It's called euglycemic DKA.
Euglycemic, meaning normal sugar DKA. That sounds hard to spot.
It can be, yes. So awareness is key. Other potential issues include orthostatic hypotension, feeling dizzy when standing up due to a drop in blood pressure because you're losing fluid along with the sugar. And one large study specifically linked canagliflozin to an increased risk of lower limb amputations, which is obviously a very significant concern and led to warnings.
Right. Definitely factors to consider.
But overall, what's fascinating here is how these newer classes, especially the SGLT2 inhibitors, are moving beyond just tackling insulin and glucose directly. They're offering broader organ protection. It really exemplifies how our understanding of diabetes and its complications is evolving, pushing towards more holistic care.
Okay, so we've covered a lot of oral medications, but not all the effective diabetes treatments are pills, right? Some are injectables, but they aren't insulin.
That's right. Let's talk about those now. First up are the injectable incretin mimetics, also known as GLP-1 receptor agonists.
Ah, GLP-1 again, like the DPP-4 inhibitors target, but these are mimicking it directly.
Exactly. Drugs like liraglutide, semaglutide, dulaglutide, they directly mimic the action of that natural gut hormone, GLP-1. And they do several beneficial things. They boost insulin secretion, but importantly, only when glucose levels are high, so lower hypoglycemia risk. They also slow down how quickly your stomach empties after a meal, which helps control post-meal spikes and makes you feel fuller.
Fuller. Does that mean they help with weight?
Yes, that's a major benefit. They often lead to significant weight loss because they also act on the brain to reduce appetite.
That's a huge advantage for many people with type 2 diabetes.
Absolutely. They offer significant A1C reduction, potential improvement in beta cell function, and as you said, weight loss. Liraglutide is also specifically FDA approved for reducing the risk of major adverse cardiovascular events like heart attack and stroke in people with type 2 diabetes and existing heart disease.
Powerful benefits. How are they administered?
They're given by injection, under the skin, like insulin. Dosing varies. Some are twice a day, some once a day, and some are even once a week, which is very convenient.
Once a week. Wow.
Yeah. And semaglutide is actually also available now as an oral pill, which is a big development.
Interesting. What about side effects for these?
The most common issues are gastrointestinal nausea, sometimes vomiting or diarrhea, especially when first starting the medication. These often lessen over time. There's also been a slight increase noted in the risk of pancreatitis, and they're generally contraindicated or avoided in people with a personal or family history of medullary thyroid cancer.
Why thyroid cancer?
That's based on studies in rodents where these drugs cause thyroid C-cell tumors. It hasn't been clearly shown in humans, but it remains a precaution.
Okay. Now, I've also heard about dual incretin agonists recently. What makes them dual?
Tirzepatide is the main example here. It's a newer drug, and it's unique because it acts on two different incretin receptors, GLP-1, like the ones we just discussed, and another one called GIP.
So hitting two targets instead of one.
Exactly. By activating both pathways, it seems to amplify the beneficial effects. We see even greater increases in insulin secretion, decreases in glucagon, slower gastric emptying, and often even more profound weight loss compared to the GLP-1 agonists alone. It's proving to be very effective.
Very interesting. And there's one more injectable class, amylin analogs.
Yes, pramlintide is the one available. Amylin is actually another hormone that's released alongside insulin from the pancreas in people without diabetes. Pramlintide mimics this hormone. It helps regulate glucose after meals by suppressing glucagon release, slowing stomach emptying, and promoting satiety, that feeling of fullness.
So similar effects to GLP-1s in some ways.
Similar in terms of slowing digestion and promoting fullness. Yes. It's typically used as an adjunctive therapy, meaning it's added on for people who are already using mealtime insulin, both type 1 and type 2.
And side effects.
The most frequent side effect is nausea, especially when starting out, but that often improves. It can also contribute to some modest weight loss.
Okay. We've covered managing symptoms and blood sugar really thoroughly, but you mentioned earlier something about potentially altering the disease itself, especially for type 1. That sounded groundbreaking.
It really is. This brings us to a truly different category, disease-modifying medications. The prime example right now is teplizumab.
Teplizumab. What is it, and how does it modify the disease?
Teplizumab is a type of drug called an anti-CD3 monoclonal antibody. Its purpose isn't just to manage blood sugar day to day. Its goal is to actually delay the onset of symptomatic or clinical type 1 diabetes in individuals who are identified as being at high risk.
High risk meaning?
Meaning people who don't have full-blown type 1 yet, but they show early signs like abnormal blood sugar regulation, that's dysglycemia, and they have specific autoantibodies in their blood.
Autoantibodies, indicating their immune system is already starting to attack the pancreas.
Precisely. Type 1 is an autoimmune disease. Teplizumab works by interfering with that autoimmune attack on the insulin-producing beta cells.
So it's like putting the brakes on the immune system's attack, hitting pause on the disease progression.
That's a great way to think about it. It's administered as an intravenous infusion, given daily for 14 days. And in the clinical trials, it showed a remarkable result. It delayed the onset of clinical type 1 diabetes by an average of 2 years.
2 years? That's incredible. Imagine getting 2 extra years before needing insulin and dealing with daily management.
It's a profound shift, isn't it? Moving from just managing the consequences of the disease to actually intervening in the disease process itself. It's the first drug approved for this indication.
What about side effects for something that modulates the immune system?
There are potential side effects, yes. Things like cytokine release syndrome, which can cause flu-like symptoms, and lymphopenia, a temporary decrease in certain white blood cells. Hypersensitivity reactions are also possible. These need careful monitoring and management during and after the infusion period.
Still, the potential impact, delaying a chronic illness like type 1, that's huge.
It really raises an important question, doesn't it? What if we could delay chronic diseases like this for even longer? It truly opens up new possibilities.
Absolutely. Okay, wow. We have covered a huge range of medications, from insulin types to various oral pills, injectables, and now even disease modification. With so many options, how on earth do doctors and patients actually make the decision? Let's try to zoom out a bit. How do these classes stack up against each other?
It absolutely has to be an individualized decision. There's no single best drug for everyone. You have to weigh the pros and cons for each person. For instance, think about the comparisons. Sulfonylureas, we said, are inexpensive and work fast. But big downsides are the weight gain and the high risk of hypoglycemia. Metformin, also inexpensive, potential for weight loss, low hypoglycemia risk, known cardiovascular benefits. But you have the potential GI side effects and that rare lactic acidosis risk, plus the need to watch kidney function.
Okay.
Alpha-glucosidase inhibitors. Maybe modest weight loss,
Wow.
low hypoglycemia risk. But they're less effective overall, have those significant GI side effects, and inconvenient dosing.
Got it.
Thiazolidinides, TZDs. Low hypoglycemia risk, convenient dosing. But you've got the heart failure risk, the weight gain, bone fractures, need for monitoring, big trade-offs.
Definitely.
SGLT2 inhibitors offer weight loss, low hypoglycemia risk, and those really important cardiovascular and kidney protective benefits. Huge pluses. But you have the specific risks of UTIs, yeast infections, and that tricky euglycemic DKA possibility, plus amputation concerns with one agent.
Yeah, complex profile there.
And GLP-1 agonists. Significant weight loss, proven cardiovascular benefits for some, but they're injectables, mostly, common GI side effects initially, and the thyroid cancer precaution. This just highlights the need for a truly personalized approach. What's best really depends on the patient's specific health profile, their other conditions, comorbidities, their A1C target, their tolerance for side effects, and frankly, cost and access.
Yeah, cost is a huge factor you mentioned. Let's touch on that again. What's a general landscape for generic availability?
That's a really critical point. Many of the older drug classes, sulfonylureas, metformin, pioglitazone, a TZD, a carbose, an alpha-glucosidase inhibitor, nitaglynide, and meglitinides, they're widely available as generics and they're generally quite inexpensive.
Makes them accessible.
Exactly. But many of the newer, often highly effective classes, like most DPP-4 inhibitors, except sitagliptin now, SGLT2 inhibitors, and GLP-1 agonists often lack generic options, or the generics are still relatively new and costly. This can be a significant barrier for many patients in healthcare systems. That recent generic availability for sitagliptin was a positive step, but there's still a long way to go to make some of these advanced therapies more affordable.
So it really sounds like managing diabetes effectively isn't just about that one glucose-lowering drug. It's about the whole picture, including protecting the body long-term.
Precisely. It's a comprehensive approach. Knowledge is most valuable when it's understood and applied, right? And this full spectrum of care, starting with lifestyle, diet, exercise, and then layering in the right medications, that's what leads to the best outcomes. We should also briefly mention other crucial adjunctive medications. These aren't primarily for blood sugar, but they prevent or treat common diabetes complications.
Like what?
Things like ACE inhibitors or ARBs. These are blood pressure medications, but they're often used specifically for kidney protection in people with diabetes and also for reducing cardiovascular events. Aspirin is sometimes recommended for cardiovascular protection, depending on the individual's risk profile. And statins, cholesterol-lowering drugs, are generally recommended for most adults with diabetes to manage cholesterol and reduce cardiovascular risk.
So it's a whole team of medications working together, potentially.
Often, yes. It's about protecting the whole body, heart, kidneys, eyes, nerves from the potential long-term impact of diabetes.
And one final note, what about alternative medicine? We sometimes hear about herbal remedies or other approaches.
It's a common question. While some traditional treatments, like certain Ayurvedic practices from India, for example, have been researched for diabetes, the current scientific evidence from those studies is generally considered insufficient to recommend them, often due to methodological flaws or small study sizes. So for now, it's really important to rely on treatments that have robust, high-quality evidence demonstrating both safety and efficacy.
Makes sense. Stick with what's proven. Well, that brings us towards the end of our really comprehensive deep dive into the world of diabetes medications. We've journeyed through so many different mechanisms, the benefits, the considerations for each class, from traditional insulins all the way to these groundbreaking disease-modifying therapies like teplizumab. We really hope that understanding these tools helps empower you, makes you feel better informed, whether it's for yourself, maybe a loved one, or just to satisfy your curiosity about how far medical science has actually come.
Absolutely. So what does this all mean for you listening? Maybe next time you hear about a new diabetes drug in the news or from your doctor, consider not just what it does, but try to think about how it does it. Is it an insulin sensitizer? Does it stimulate secretion? Does it slow absorption? Or does it work through the kidneys like the SGLT2s? Knowing the how, gives you a much deeper appreciation for the really cutting-edge science involved in managing this incredibly complex condition. And it's important to remember, the landscape of diabetes treatment is constantly evolving. Research is ongoing. Who knows what new mechanism might be discovered next? Something that could potentially change everything again.